Hi, this is Ellie Fishman, and I am now live here from our office. My office. It's Friday, August 5th. Hope everyone's having a great week. A lot of people must take off on Fridays because the traffic to work was nothing today, and the parking garage was like two-thirds empty based on what I usually see when I get here about 6:45. So I guess a lot of people are taking advantage of the dog days of summer. Kids I know start returning to school in a couple of weeks. Many schools, colleges, even elementary schools return in mid-August, not like the old days in New York where everything happened after Labor Day. So I guess everyone is squeezing out what they can for the summer. I'm in my office here. Everything's working well. Last night we had this gigantic thunderstorm, which usually doesn't bother my office, but my computers crashed and the network went down, and there was all sorts of fun things. But nevertheless, working now. And what I'm speaking about today is lung cancer screening. Now, lung cancer screening month is in November, I believe. And lung cancer screening is the best thing we could do to prevent or detect early lung cancer. Now, a lot has been spoken about with lung cancer screening going back for many decades. In the 70s and even 80s, people tried doing lung cancer screening with chest x rays. The results were never great because chest x rays are going to miss small tumors. And when you finally see something on chest x ray, it's probably a little bit late. The goal, of course, screening is to pick up things early where you can intervene and change the outcome. So picking up a small lung nodule before it metastasizes can basically lead to a cure of that patient. So that indeed is very good. If you look at some of the numbers, lung cancer, 235,760 patients will be diagnosed with lung cancer this year, and 131,880 will die of lung cancer in the US. So it's big numbers. Smoking is the most common cause of lung cancer. There are other risks: secondhand smoke, family history, prior radiation therapy, asbestos exposure, many of the toxic things like chromium, nickel, tar in the workplace, exposure to radon. But at the end of the day, it's smoking. You can be a non-smoker and get lung cancer, but the most common reason people get lung cancer is smoking. So the first thing I'll say is when you screen for lung cancer, and this has been many articles and it's actually a requirement, if patients are smoking, you need to tell them to stop smoking. You can't get a screening chest CT, which is negative, and say, all right, it's negative. Let me go celebrate and smoke 2 packs of cigarettes. You really need to work on prevention. So you got to get people to stop smoking. So that's pretty straightforward. No magic to that. Now let's look at what the screening guidelines are. Now, there's been lots of arguments over the years. When should you screen? Age 40, age 50, age 60? How long should you screen for? Once every year? How should you do it? All these are questions. Now, there's been lots of arguing, debating, and the good news is we look at facts and numbers, and the most recent recommendations from the different societies and actually the National Lung Cancer Screening, the U.S. Preventive Services Task Force, which at the end of the day makes the final decision. What they said was that adults age 50 to 80 who have a 20-pack year smoking history and currently smoke or have quit within the past 15 years, it's recommended that they get annual screening for lung cancer with a low-dose CT scan. Okay? Screening should be discontinued once a patient has not smoked for 15 years or develops a health problem that limits life expectancy or the ability or willingness to have curative surgery. There's no point in screening someone where you find a lung nodule, you can't biopsy them, and you can't treat them. So again, a little bit of common sense as patients get older. But now it's age 50, not 55. It's 20-pack years and not 30-pack years. Remember, a pack year means if you smoke a pack of cigarettes a day for a year, that's a pack year. If you smoke 2 packs a day for a year, it's 2-pack years. So again, also 15 years, 15, 1-5 is the magic number. If you have stopped smoking 14 years ago, you still need to be screened. 15 years ago, you're back to baseline. You don't need to be screened. And we'll screen you every year with a low-dose CT. There is good information on the ACR website, how to perform the studies, how to do the protocols. Every manufacturer, Siemens, GE, Philips, has protocols for doing low-dose CT. And again, you're looking for a lung nodule. You're not looking for mediastinal masses or adenopathy. It's important to read the studies, report the studies, and have the recommendations. ACR has a boilerplate that you can use, and it's very nice for doing that. It's also important to think about some of the things with lung cancer screening. Again, the importance of making certain that patients have stopped smoking. It's also important when you do lung cancer screening to look at the coronary arteries, since you get that for free. And if the patient has calcium in the coronary arteries, then you could say, well, maybe they ought to look at the patient's coronaries, or look at do a cardiac exam, or look at the patient's lab values, whatever you want. But again, when you get a coronary CT, you get a lot of other information for free: patient's body fat, patient's bone state, as well as the coronary. So that all becomes very, very important. Now, if you go to the ACR site, and I mentioned that the ACR site is very good, the ACR, and I'm going to type it in now, ICR.org. That's the American College of Radiology. And on their home, they have a lot of things from the appropriateness criteria, but also on the front page, they have that you could become a site that does lung cancer screening. They will make you follow certain rules, which is good, which makes certain that you are doing low dose, you're doing the right protocols, you're reporting correctly. They also have a lot of lung cancer screening resources where you can read about interpretation of these studies and some facts. You can test yourself. The ACR CT accreditation is something you know about, but there's a designated lung cancer screening center. You get a plaque for the wall, and it's only $400 per site. So it's really pretty cheap. They also have lung cancer screening boot camp webinars. These are available on demand, and I think they're free for ACR members. There's an incidental findings one-page report that also can be used when you're doing lung cancer screening. So there's lots of simple things that can be done. So I think every one of us is doing some sort of lung cancer screening. You want to make sure it's something you're using in your practice. I think that becomes very, very important to do that. Again, it's helpful if there's one physician, usually a pulmonary physician, a radiologist interested in lung, to be the leader of the group, to make sure things are done correctly, make sure you're doing that with the technologist, doing the protocols correctly, doing the interpretation correctly. And again, the free toolkit from the ACR, the toolkit includes a screening quick reference guide, some templates for patients and referring providers, a patient safety infographic. There's lots of good information on the site, and I think it can be an easy way of doing it. And again, patients who get lung cancer screening because they were smokers and they have some guilt, you need to deal with them in a nice fashion. Again, remember, just because you have a lung nodule and you need a follow-up, doesn't mean you have lung cancer. Remember, from the original screening, it took 360 nodules to find one cancer. So a lot of patients are going to have small nodules that are not going to be significant. So again, very, very important. So when we talk about screening in radiology, we talk about mammography, we talk about virtual colonoscopy, we talk about lung cancer nodule detection. Strong screening modalities that can help improve the health of our patients. And it's very important to be really good at these studies, be working with our patients, with our providers, to make sure everybody is doing everything correctly. So that's what I'm going to tell you today. And this was YouTube Live. Have a great weekend, and we'll see you guys later. Bye-bye.